I am Dr.Sourabh Patwardhan from Nandadeep Eye Hospital, Sangli, Maharashtra, India, and in this video I'll be showing few of my mistakes and what I learned from those mistakes. So this is a first case, 45-year-old patient who is uncooperative, not fit for general anesthesia. We have sedated the patient and we thought that we'll be able to carry out the surgery. So first the blade goes in and you will see here, even before I could stabilize the globe, the patient moves the eye and there is a very big side incision which is created, which was not intended. So whenever the side incision is used in this case, it will leak profusely, causing problem in the fluidics of the surgery. I learned from this that we must stabilize the globe before taking incision. Otherwise, inadvertently we may make a very large incision and which may have deleterious effect. In case number 2, you can see that the surgeon has started with very small capsulorhexis there. The first wave passes, nucleus is tapped but maybe not adequate, and then tries to have another hydrodissection wave and watch what happens. I am sure you must have observed that the fluid ruptures the posterior capsule there, and at the same time you see the pupillary snap sign. Pupil constricts momentarily and there is deepening of the anterior chamber. Surgeon didn't notice it during hydrodissection and that's what happened, the nucleus is dropping. So lessons learned, make sure that CCC is of adequate size. Don't make less than 4 mm capsulorhexis because there is always a high chance of anterior capsular block while doing hydrodissection and can cause hydrorupture of the posterior capsule. Also, after the first fluid wave, make sure that you tap the nucleus and whatever fluid is accumulated behind comes out. The ideal size of rhexis for routine case is 4.5 to 5.5 mm. You don't want a very small rhexis which may have these complications. For hard mature cataract, PXF, retinitis pigmentosa, high myopia and pediatric cases, it should be more than 5 mm to avoid anterior capsular phimosis. For posterior polar cataract, we can keep it between 4.5 to 5 mm, which improves the ease of optic capture if it is needed in PPC. Let's move on to case number 3. Just watch this case very carefully. The surgeon has filled the anterior chamber with viscoat completely. No cohesive OVD was placed underneath. So there is no other OVD or fluid other than viscoat there in the anterior chamber, and what we are seeing are the lens plumes. And what we need to observe is the incision area. You can see that it's becoming whitish, indicating it's a wound burn. So the tip was blocked because of the viscoat. Low vacuum was used and that's why it could not clear off the viscoat, and as the phaco energy was delivered, the energy stayed around the phaco tip, causing this wound burn. The surgeon was oblivious to this fact now and completed the surgery, but at the end realized that it's a very severe wound burn. You can see the fish mouthing and had to be sutured. There are other ways to tackle this using the tenon patch graft or corneal patch graft, but lesson learned here is watch for this sign. If there are these lens plumes which are there, you must look for the block of the phaco tip. Another sign for blockage of the phaco tip is loss of fallibility during the surgery. Like in this case, suddenly the pieces stopped moving towards the phaco tip. So common causes of blocked phaco tip are while doing hard cataract. If you use only torsional phaco and use very low vacuum, particularly when the anterior chamber is filled with viscoat or hylucoat and tip is not cleaned properly or tip is bent. How to clean this blocked phaco tip? You can cover the tip with fluid filled chamber and give longitudinal power burst. You can prime the tubing, flush the probe and tip with distilled water or change the tip. So lens plume and no fallibility, you must watch for the signs of tip blockade and avoid complete fill of AC with heavy dispersive OVD. In case number 4, we'll be tackling a dense or hard mature cataract in a diabetic patient. A capsulorhexis size of 4.6 by 5 mm was made, and I was thinking whether it is adequate for this denser cataract or not. But I thought it's adequate for this case and I moved on. So first made a nice deep trench there and moved on to the chopping maneuvers here. And at this point I was unaware that something was happening at this point. and you will also notice it now that the anterior capsular axis has already given way and now the nucleus is tilting. So when did this happen? The reason for this was excessive stretching when I was trying to chop. So you can see that I was using a shorter chopper there and trying to pull these pieces apart from the anterior edge of this nucleus, and that led to overstretch on the capsular axis margin and it gave way. And not just it gave way, even it ran to the posterior capsule, and that's why you can see that the nucleus is tilting now. And when did I notice this? During the surgery. When I tried to rotate this nucleus, I could see the edge of the nucleus there, and you don't usually see the edge of the dense nucleus unless it is a shrunken nucleus or if there is a posterior capsular dehiscence, which was the case here. So lessons learned: use long chopper and go deep for dividing the pieces, avoiding overstretch of the capsule. Case number 5, a plate haptic trifocal IOL being placed in the bag. You can watch the cartridge. The tip of the injector is right at the center of the bag there, and when the trailing haptics are pushed in the bag, I realized that the posterior capsule had given way while antihyaloid was intact. IOL was in the bag. Now what should I do next? Other eye, the patient had already received the same IOL and patient was quite happy with that. I didn't have a 3-piece multifocal at this point, so I decided that the IOL was quite stable in the bag and just washed off the visco without deepening of the anterior chamber here. And this is 1 month after surgery. The patient was doing fine. But why did this happen? What I should do differently in the next case? So when I reviewed this video, I realized that it's a plate haptic IOL which is big. The injector cartridge was deep inside the bag, so it was not giving any space for the IOL to unload itself in the bag, and it pushed on the posterior capsule. Posterior capsule was probably separated from the antihyaloid. Because of that, the posterior capsule was redundant and visco might not be filling the bag completely, so it dragged the posterior capsule and caused the tear. So fill the bag with OVD completely, make sure the bag is deep and completely filled, and injector cartridge should be just inside the incision and not into the bag, thus giving the IOL required space to unfold itself in the bag. So do not push the injector too inside the bag and make sure PC is not stretched during the insertion of the IOL. These are the things I learned from my mistakes. Thank you.